Hey guys, tonight I want to make a statement that I think will sound wrong for about 3 seconds, and then deeply, uncomfortably correct. Fentanyl, somehow, is no longer the most frightening thing in the opioid crisis. In fact, at this point, it is almost the good news. Which is a terrifying sentence considering the substance in question has killed more Americans than every war the country fought from Vietnam through the Gulf War combined. It remade the drug supply so completely that heroin, actual heroin, the thing that defined a century of drug panics, the thing parents warned children about, the thing movies built entire third acts around, became almost secondary to the synthetic opioids replacing it. Overdose deaths in the United States climbed from roughly 16,000 a year to more than 80,000 within about a decade, numbers so large that public health officials reportedly had to redesign the charts tracking them because the old ones physically stopped scaling properly. And yet, there is something moving through the drug supply right now that is even more powerful, more unpredictable, and in many ways more dangerous than fentanyl itself. It does not have a household name. It does not appear on the test strips that harm reduction programs distribute, so people can check their drug supply before using it. The overdose reversal medication that became standard during the fentanyl crisis works on it, but may not work fast enough, or in the doses most people carry. It has been found in supplies sold as heroin, in pressed pills sold as oxycodone, in cocaine. Most of the people who have encountered it did not know they were encountering it. It is called Nitazenes, a family of synthetic opioids so potent that the pharmaceutical company that originally synthesized them looked at the data and decided the world was better off without them. They were wrong about that last part. To understand how the opioid crisis arrived here, you have to understand that it has never moved toward caution. It has always escalated. Every response created the conditions for the next wave, and the next wave was always worse than the response had been built for. It begins with a decision that made sense at the time. In the 1980s and 90s, pharmaceutical companies produced a flood of prescription opioids into communities that had asked for help with pain. Oxycodone, hydrocodone, Vicodin. Pills designed for cancer wards that ended up in the medicine cabinets of people who had hurt their backs. Pills that sat in medicine cabinets, got found, got taken, ran out, and then got needed again. The pills created dependency. Dependency created demand. And demand, when the supply became inconvenient, went looking. When prescriptions tightened, the people who had become dependent needed an alternative. Heroin was cheaper and, in many communities, more available than a legitimate prescription for pain medication. The crisis shifted. The thing that had started in doctors' offices moved into the streets. Then fentanyl arrived. Fentanyl is approximately 100 times stronger than morphine. Illicit chemists discovered it could be synthesized cheaply, shipped in quantities small enough to fit in an envelope, and mixed into heroin in amounts so small they were invisible to the naked eye. A few kilograms distributed carefully could produce hundreds of thousands of doses. A few kilograms distributed slightly less carefully could produce something else entirely. Drug dealers are not pharmacists. The mixing was not consistent. The margin between the dose that produces the desired effect and the dose that stops breathing is, with fentanyl, not something that accommodates imprecision. Overdose deaths climbed in a way that required the people making the charts to rebuild the charts. The scale of it did not fit inside existing frameworks. The government moved to schedule fentanyl analogues. Pressure was applied to China, the primary production source, to do the same. China complied more or less in 2019. Supply routes shifted. The supply did not stop. It adapted, embedded deeper into existing networks, and kept moving. None of this stopped it. What it did was create a business problem. And in this particular industry, business problems tend to get solved in a specific direction. When fentanyl came under serious enforcement pressure, the chemists producing it needed an alternative with the same profile: extreme potency, tiny volume, easy to ship, not yet scheduled. Scheduling a specific compound takes time. It moves through bureaucratic channels at the pace of government. Producing a structural variant that sits outside the existing schedule takes, for someone with the relevant chemistry training, considerably less of everything. The answer was in published pharmaceutical literature from the 1950s and 60s, research conducted by legitimate scientists at legitimate companies, describing a class of compounds they had studied carefully and then set aside because the compounds were considered too dangerous to bring to market. That research was still there. Synthesis routes, binding affinities, potency estimates, everything needed, organised and preserved for 60 years by researchers who had assumed the information would only ever be used to understand why not to proceed. Nobody broke into a vault. Nobody reverse-engineered anything from scratch. They opened a journal. The compounds were called Nitazenes. The one the original researchers had found most alarming was etonitazene, synthesized by a Swiss company called Ciba in 1957. It is approximately 1,000 times stronger than morphine. 1,000. Morphine is what hospitals reach for after surgery, after serious injury, after other options have admitted defeat. Etonitazene is what you would reach for if morphine had failed. The patient had somehow survived a war, and you had also run out of perspective entirely. CIBA made the correct call. The margin was too narrow, the risk too high, and they moved on to developing compounds that would merely make you drowsy. They filed the research in the scientific literature, which is to say, they published it, for anyone to find. Nitazines belong to a chemical family called benzimidazole opioids. This distinction matters more than it might sound. Fentanyl, heroin, morphine, oxycodone. They're all built on variations of the same basic chemical scaffold, which is why the tests designed to detect them work across the whole family. Nitazenes are built on a completely different scaffold. Structurally, they are not related to fentanyl. They are not related to heroin. They are their own thing entirely, which is precisely why fentanyl test strips cannot see them. The test is not designed to look for something this structurally different, and so it does not. A person checks their supply. The strip comes back clean. They proceed. Potency-wise, the range across the nitazene family is wide but consistently alarming. Isotonitazene, the first to appear in the illicit supply, is roughly comparable to fentanyl, which already sits 100 times above morphine. Metonitazene is estimated at several times more potent than that. Protonitazene higher still. Etonitazene, the original, sits at around 1,000 times the potency of morphine. The floor of this family is fentanyl level. The ceiling is considerably above it. What this means practically is that the margin for error, already razor-thin with fentanyl, narrows further. A person using a nitazene-contaminated supply without knowing it is not experiencing what they expect. The effect arrives faster, hits harder, and the window between the dose that produces euphoria and the dose that stops breathing is, in some cases, almost theoretical. Nitazenes first appeared in the illicit drug supply in 2019. Isotonitazene, found in seized samples in the American Midwest and in Europe nearly simultaneously, by forensic labs running screens they had not previously needed to run. It had not been on any watch list. It did not appear on standard drug tests. The harm reduction workers and emergency physicians and toxicologists who first encountered it had to look it up. A substance was circulating in drug supplies, reaching people, killing some of them, and the professionals trained to respond were encountering its name for the first time. Not because they were unprepared generally, because the substance had been in a filing cabinet since the Eisenhower administration, and there had been, until 2019, no particular reason to prepare for it. The response came. The DEA placed isotonitazene into Schedule 1 in October of 2020. Reasonable. Also, a specific compound had been scheduled while the synthesis knowledge required to produce every structural variant remained in the same publicly accessible literature it had always been in. Within months, metonitazene appeared in seized samples, then protonitazene, then etodernitazene, then flunitazene. each one different enough from the scheduled compound to sit outside the order's language, similar enough to serve the same market. The fentanyl era had already run this exact sequence. Schedule a compound, a variant appears, schedule a variant, another appears. And the nitazene era ran it faster, because the original CIBA research had described not one compound but an entire class. There were options, the chemists had the menu. By 2023, more than 14 distinct nitazene analogues had been detected across the United States and Europe. 14 compounds, 3 years. The DEA eventually moved to schedule a broader class collectively. Whether that holds is a question the fentanyl chapter already answered. 14 compounds in 3 years is not a contamination problem. It is a product line. Naloxone, the overdose reversal medication distributed widely during the fentanyl crisis, works on nitazenes. The problem is not whether it works. The problem is the dose. With fentanyl, 2 milligrams was usually enough. With nitazenes, some reversals required 4 doses or more. The kits people carried had been built for the last drug, not this one. In 2019, forensic labs in the American Midwest began pulling an unknown compound from toxicology screens. Ohio, Illinois, Indiana. The same states that had been ground zero for fentanyl were now returning results that didn't match anything on the standard panels. The substance had no name in the system. It had no entry on any watch list. The people who had died using it had no idea what they had taken. And the fentanyl test strips that harm reduction programs had been distributing for years, the ones designed specifically for this population, in these states, after everything fentanyl had already done, came back clean. They found nothing. Because nitazenes are not fentanyl, and the tools did not know the difference. The DEA's Special Testing and Research Laboratory sits in Sterling, Virginia, and its job, broadly speaking, is to identify things that should not exist. Novel compounds, unknown adulterants, substances that arrive in evidence bags without a name and leave with one. In 2019, the lab began receiving samples from Midwest field offices that did not match anything in the system. The mass spectrometry results came back with a molecular signature that was not heroin, not fentanyl, not any of the fentanyl analogues the lab had been tracking for years. It was something else, something the panels had not been built to find, because there had been no reason to build them for it. The analysts ran the signature against the databases. It took time. What they eventually found was not in the contemporary drug surveillance literature. It was in pharmaceutical research from the 1950s. The compound had a name already. It had always had a name, Isotonitazene. First described in the scientific literature in 1957, synthesized by a chemist at a Swiss pharmaceutical company, studied carefully, and then set aside. The DEA lab was not discovering something new. It was encountering something old that had decided, after 60 years of quiet, to become a problem. The chemist's name was Essio Zürcher. He worked for CIBA, a Swiss pharmaceutical company based in Basel, that would later merge and eventually become Novartis. A transformation that suggests the company processed a great many chapters in its history and kept moving. In the mid-1950s, Zürcher was part of a research program with a straightforward goal: find a better analgesic. Something faster acting than morphine, something that could be used in surgical settings where speed of onset mattered. The pharmaceutical industry in the post-war period was producing genuine medical breakthroughs at pace, and pain management was one of the active frontiers. Zürcher was doing legitimate science in pursuit of a legitimate goal. The context matters. The 1950s pharmaceutical research environment was one of genuine optimism about what chemistry could accomplish. Penicillin had transformed infectious disease treatment within a decade. Insulin was being synthesized. The idea that the right molecule, properly designed, could solve most problems medicine was still struggling with was not naive. It was, for a while, largely correct. Pain was one of the problems. Morphine worked, but it was derived from opium poppies. It was slow to act, and its side effects and dependency potential were well understood and poorly managed. The race to find a synthetic analgesic that was faster, cleaner, and more controllable was being run by pharmaceutical companies across Europe and the United States simultaneously. CIBA was one of the most productive research operations on the continent. Zerker was one of its chemists. The program was well-funded, well-staffed, and entirely legitimate in its aims. What made the benzimidazole synthesis program distinctive was its scope. Zerker did not synthesize Isotonitazene alone. He synthesized a range of benzimidazole compounds, structural variations on the same scaffold, each one slightly different, each one tested for its analgesic properties and its safety profile. Some were less potent, some were more potent, some had better safety margins than others. The research was systematic in the way serious pharmaceutical chemistry is systematic. Build a compound, test it, measure the result, adjust the structure, test again. The goal was to find the compound in the family that had the best combination of properties, effective enough to be useful, safe enough to be administered. What he found was Isotonitazene. The compound worked. That was not in question. It bound to opioid receptors with an affinity that produced powerful analgesia. Powerful being, in this case, a significant understatement. The problem was the numbers. The dose required to produce pain relief, and the dose required to cause respiratory depression, the mechanism by which opioids kill, were separated by a margin so narrow it was less a therapeutic window than a theoretical one. In pharmacology, this ratio has a name, the therapeutic index. A high therapeutic index means a drug has a wide margin between effective and lethal. A low one means the margin is thin. Isotonitazenes was, to use the clinical term, not reassuring. CIBA made the decision that the research suggested. The compound was too potent, the safety margin too narrow, the risk to patients too high. They would not pursue it. They would not run trials. They would not seek approval. The research program moved on to other compounds, other approaches, other problems that did not have this particular characteristic of being simultaneously very effective and very dangerous. What they did do, because this is what scientists do, because this is how knowledge accumulates, because the entire system of scientific progress depends on researchers publishing what they find so that others can build on it or be warned by it, was document it. Zerker's findings were documented and published. Isotonitazene entered the pharmacological record. The synthesis route, the binding affinity, the potency estimates, the decision not to proceed and the reasons for it. All of it went into the journals, indexed, archived, accessible. The intention was transparency. The assumption was that the information would function the way such information was supposed to function, as a record of what had been tried and why it had been set aside. That assumption held for 60 years. What happened in those 60 years is, in its own way, a strange kind of nothing. Etonitazene and its benzimidazole cousins did not disappear from the scientific literature. Literature does not disappear. That is rather the point of it. But they receded. Occasional pharmacological studies reference the compounds. The DEA, in its reference materials on controlled substances, noted their existence. A handful of researchers with specific interests in opioid receptor pharmacology encountered them in the course of their work. For the most part, though, the nitazene family existed in the space that most pharmaceutical dead ends occupy, acknowledged, filed, functionally forgotten. Nobody was making them. Nobody was looking for them. The drug crisis of the 1980s, which centered on heroin and then on crack cocaine, had no particular use for a class of compounds that required advanced chemistry to produce and had no established supply chain. The prescription opioid crisis of the 90s and 2000s was driven by compounds that were already in legitimate production, oxycodone, hydrocodone, not by novel synthetics excavated from mid-century research. Even as fentanyl began its takeover of the illicit market in the early 2010s, nitazenes remained in the background. Fentanyl was the thing. Fentanyl analogues were the thing. The race to schedule fentanyl variants and the race to produce new ones occupied the attention of both regulators and illicit chemists, and then something shifted. It is worth noting what the DEA knew about nitazines during those decades of quiet. The agency maintains reference databases on controlled and potentially controlled substances, a catalogue of compounds that have been studied, identified or flagged as having potential for abuse or harm. Nitazenes appear in those databases. The benzimidazole opioid class was not invisible to the agency. It was filed under the category of compounds that were known to be potent, known to be dangerous, and not known to be circulating in the illicit market. The DEA's scheduling priorities are reasonably driven by what is actually in the supply. A compound sitting in pharmaceutical literature that nobody is producing is not an enforcement priority. The agency tracks what it can track, and for 60 years there was nothing in the nitazene family to track. This is not a failure. It is a description of how the system functions. The system is reactive by design. It responds to what appears, not to what might appear. The limitation of this design is that it produces a detection lag. By the time a novel compound reaches the enforcement infrastructure's attention, it has already been in the supply for some period. How long depends on how quickly the forensic labs identify it, how quickly the identification reaches the scheduling process, and how quickly the process concludes. With nitazenes, the lag was approximately 14 months from first detection to first scheduling action. With a compound of this potency in an already saturated drug market, 14 months is a long time. In 2019, China, responding to sustained diplomatic pressure from the United States, placed a broad class of fentanyl analogues under domestic, scheduling controls. The move was significant. China had been the primary production source for illicit fentanyl and its analogues, and the scheduling action disrupted that supply chain in ways that were real, if not permanent. Illicit producers needed alternatives, not weaker alternatives, not different categories of drug, alternatives with the same essential profile, extreme potency, synthesizable from accessible precursors, shippable in tiny volumes, not yet scheduled anywhere. Someone, and the anonymity here is not a narrative convenience but a genuine feature of the problem, because the people who made this decision have no names in the public record, went looking. The search did not require access to classified information or proprietary databases. It required access to the kind of university library database that students use to write papers. Pharmaceutical research from the 1950s and 60s, peer-reviewed and indexed. Synthesis routes, binding affinities, potency estimates, the whole pharmacological picture. Ezio Zerka's work was in there. The compounds he had synthesized, the results he had found, the decision not to proceed, all of it in the databases exactly as he had left it. The intention had been that future researchers would find it and understand why not to proceed. Some future researchers read it and understood something else. The first sample containing Isotonitazene, a structural cousin of etonitazene, similar enough in chemistry to share its essential properties, different enough in configuration to sit outside the specific scheduling language that covered other compounds, was identified in seized material in the American Midwest in 2019. The DEA Special Testing and Research Lab ran the analysis, matched the signature to the research, and filed a report. The report named the compound, described its properties, noted its relationship to the broader nitazene family and to the mid-century pharmaceutical research that had documented it, flagged it as a substance of concern, recommended scheduling action. This is how the system is supposed to work. Unknown compound appears, lab identifies it, name is assigned, regulatory process begins, the compound moves towards scheduling. The system worked. The report was filed. The process began. What the report could not account for, what no report in this system can account for, is that the process takes time, and the compounds do not wait for it. By the time Isotonitazene was formally placed into Schedule 1 in October of 2020, it had already been linked to overdose deaths in the Midwest, in Canada, in Belgium, in the United Kingdom. 14 months had passed between the first detection and the scheduling action. 14 months is not a long time in regulatory terms. In terms of what a compound with this potency and this distribution network can do in 14 months, it is considerable. During those 14 months, the compound was moving. The supply chains that had been built for fentanyl analogues were carrying a new product. Distributors were mixing it, at ratios they did not fully understand, into supplies they were selling as heroin or as something else, to people who had no idea the supply had changed. Forensic labs in multiple countries were running screens that did not find it. Medical examiners were attributing deaths to fentanyl or to unknown opioids, because those were the categories available to them. Harm reduction programs were distributing fentanyl test strips that came back clean, and the regulatory machinery that would eventually name the compound and place it under Schedule 1 was working at the pace it was designed to work, which is to say, carefully, deliberately, and not at the pace of the supply chain it was trying to address. The 14 months between first detection and scheduling produced a body of documentation, seizure reports, toxicology findings, overdose death attributions, public health alerts issued by jurisdictions that had identified the compound and were trying to warn the communities most at risk. That documentation is the record of the gap. It is the evidence of what the compound did in the time the system needed to name it. And the scheduling action, when it came, was for Isotonitazene specifically. One compound, named, described, placed into Schedule 1. The synthesis knowledge that produced it, the Zerker research, the broader Nitazene literature, the full pharmacological picture of an entire chemical family, remained exactly where it had always been. The DEA analysts who identified Isotonitazene in 2019 were good at their jobs. They found the compound. They named it. They traced it to the original research. They filed the appropriate reports and initiated the appropriate process. Nothing about their response was inadequate given the tools and authorities they had. What they could not do, what the system they operate within was not designed to do, was move at the speed of the supply chain they were tracking. The supply chain does not have a regulatory process. It does not require committee approval or public comment periods or interagency coordination. It requires a chemist, a precursor supplier, and a shipping address. The compounds come from the same grey market networks that moved fentanyl analogues. Suppliers in China, India, Eastern Europe, operating in jurisdictions where the specific compounds were not yet scheduled, shipping through commercial carriers with falsified documentation, reaching distributors in the United States through the same channels that had been developed over years of fentanyl trade. Isotonitazene was named in October of 2020. Metanitazene appeared in seized samples within months. The naming had not stopped the thing that was named. It had started a clock, and the clock, as it turned out, was running faster than the regulatory system could follow. Ezio Zerker died in 2014, 5 years before his research reappeared in the American drug supply. He had spent his career in legitimate pharmaceutical science. The work he published in 1957 was published in good faith, in service of a system of scientific knowledge sharing that has produced most of the medical advances of the last century. He could not have known. There is no reasonable version of 1957 in which a chemist publishing findings about compounds too dangerous for medical use would anticipate that those findings would become, 60 years later, a production manual. His notes survived. They are still in the databases. They will be there tomorrow. There is a specific moment in the story of every illicit synthetic opioid where the chemistry stops being the interesting part and the economics take over. With fentanyl, that moment came when someone calculated what it actually cost to produce a dose. The number was so small, fractions of cents, at scale, that it changed the logic of the entire drug trade. Heroin required cultivation, harvest, processing, and a supply chain that ran through agricultural regions, seasonal variations, and the unpredictabilities of growing things in the ground. Fentanyl required a laboratory, precursor chemicals, and a chemist. The product was measured in micrograms. It could be shipped in an envelope. The economics were, from a purely business perspective, extraordinary. Nitazenes are fentanyl's logic taken further. The active dose of a compound like metanitazene or protonitazene is measured in micrograms, millionths of a gram. A single gram of material at microgram level dosing contains enough active substance for thousands of individual doses. A kilogram, which is not a large quantity to move across international borders and which fits comfortably in a small package with room to spare, represents a distribution potential that heroin, by weight, cannot approach. The shipping cost per dose is, at this scale, effectively zero. The raw material cost purchased from grey market chemical suppliers at prices comparable to fentanyl analogues is low enough that the economics of production are compelling even before the markup that happens as product moves through distribution networks. This is not a drug. It is a logistics problem with an unusually high margin. The grey market chemical supply chain that produces nitazenes is not a new infrastructure. It is the same infrastructure that produced illicit fentanyl and its analogues, adapted, rerouted, and still operational. When China placed broad scheduling controls on fentanyl analogues in 2019, under diplomatic pressure from the United States, the supply chain did not close. It relocated. Production shifted towards suppliers in India, Eastern Europe, and remaining grey market operators in China working around the new restrictions. The distribution networks, dark web marketplaces, direct-to-dealer shipping with falsified customs documentation, commercial carriers used without their knowledge, were already established. They had been built over years of fentanyl trade. They required no modification to carry a different payload. The compounds arrive in the United States as powder, typically shipped in small quantities with mislabeled documentation, listed as industrial chemicals, research materials, or substances with names chosen specifically to avoid triggering automated screening. They clear customs at a rate that suggests the volume of international parcel traffic is, from an interdiction standpoint, an essentially unsolvable problem. The DEA and Customs and Border Protection intercept shipments. They intercept a fraction. The fraction that gets through is sufficient to supply a market. The distributor who receives the powder does not need to understand the chemistry. They need to understand the ratio, how much active material goes into a batch of whatever they are selling, and they need to understand the market signal, which is that their supply hits harder than the competition's. This is the contamination as product differentiation problem, and it is not theoretical. It is documented in fentanyl supply and suspected with increasing confidence in nitazene supply. Some distributors add nitazene compounds deliberately, not as a cutting agent that reduces potency, but as an adulterant that increases it. The supply that produces more intense effects gets repeat customers. The customers attribute the effect to quality. They do not know what compound is producing it. The distributor may not know either, or may know exactly, and may have calculated that the risk to the customer is the customer's problem. Before specific nitazene compounds were scheduled, they occupied a legal category that the synthetic drug trade has exploited since the first wave of novel psychoactive substances in the 2000s, the research chemical grey area. A compound not yet listed in Schedule 1 is, technically, not a controlled substance. It can be sold, it can be purchased, it can be shipped across borders with documentation that lists it as a legitimate chemical, product for research purposes. This is the same legal grey area that allowed bath salts, synthetic cannabinoids, and dozens of fentanyl analogues to circulate widely before regulators caught up. The grey area is not an accident of poor legislation. It is a structural feature of a scheduling system that can only prohibit what it has already named. Novel compounds are by definition not yet named. The window between synthesis and scheduling is the window in which the grey market operates most freely. Several nitazene compounds were offered for sale on dark web marketplaces during this period, marketed explicitly as research chemicals or under names designed to be ambiguous. DEA operations resulted in seizures of packages containing nitazene powder, shipped from overseas suppliers, intercepted at ports of entry, at customs facilities, in postal distribution centres. Several prosecutions occurred under Federal Analog Act provisions, which allow prosecution for substances substantially similar to scheduled compounds, even when those substances are not themselves scheduled. The prosecutions were real. They were also a fraction of the volume moving through the same channels that had carried fentanyl analogues for years. In legitimate pharmaceutical markets, a drug with an extremely narrow therapeutic index, the ratio between an effective dose and a dangerous one, would never reach patients without extensive safety protocols, calibrated dosing, professional administration, monitoring. The entire infrastructure of medical practice exists, in part, to manage the gap between what a drug can do for a patient and what it can do to one. With nitazenes in the illicit market, none of that infrastructure exists. The ratio between the dose that produces the desired effect and the dose that causes respiratory depression is, for some compounds in this family, almost theoretical. And the person using the supply has no information about what compound they have encountered, what dose they have taken, or what the margin is. The pressed pill problem makes this concrete. In the fentanyl era, counterfeit oxycodone tablets, pressed to look exactly like the pharmaceutical version, the same size and colour and markings, became a major vector for illicit fentanyl. The DEA and drug checking services documented the M30 pill, a tablet pressed to resemble a 30mg oxycodone tablet, containing illicit fentanyl in quantities that varied from pill to pill because the pressing process is not pharmaceutical grade. By 2022, drug checking services in North America were finding nitazene compounds in the same pressed pills. A person purchasing what appeared to be an oxycodone tablet, expecting the experience of an opioid they had taken before, was instead encountering a compound potentially many times more potent, in a dose they could not estimate, from a source they could not verify, with no safety margin they could rely on. The pill looked the same, the effect did not. The economics of the response do not match the economics of the problem. This is perhaps the most structurally significant feature of the nitazene crisis, and the one that receives the least attention in policy discussions. Producing nitazenes requires precursor chemicals, a synthesis route, and a supplier willing to ship. The synthesis route is in published literature. The precursor chemicals are available. The suppliers exist. The cost of entry is low and the margin is high. On the other side of the ledger, detecting nitazenes in a drug supply requires mass spectrometry equipment, laboratory-grade analytical instruments that cost tens of thousands of dollars, require trained operators, and need ongoing maintenance and calibration. The fentanyl test strip, which retails for roughly $1 and requires no training to use, cannot detect nitazenes. It was not designed to. The immunoassay chemistry it uses is specific to fentanyl and structurally similar compounds. Nitazenes are not structurally similar. The result is an asymmetry that consistently favours production over detection. A drug-checking service operating in a city with high rates of opioid use disorder can, with mass spectrometry equipment and trained staff, identify nitazene compounds in samples brought in by people who use drugs. That service can then issue an alert. This supply contains this compound. People who receive the alert can adjust their behaviour, use less, with someone present, carry more naloxone. This is harm reduction working as intended. The problem is access. In most American cities, this service does not exist. The equipment is expensive. The funding is inconsistent. The political will to allocate public money to drug-checking services for people who use illicit drugs is, in most jurisdictions, limited. The geographic dimension of the supply chain is worth understanding in some detail, because it shapes what interdiction can and cannot accomplish. After China's domestic scheduling of fentanyl analogues in 2019, production shifted. Suppliers in India, particularly in chemical manufacturing clusters in Gujarat and Maharashtra, became significant sources of nitazene precursors and, in some cases, finished compounds. Eastern European suppliers, operating in jurisdictions where the compounds remained unscheduled for longer, also entered the market. The routes are not simple point-to-point shipments. They involve multiple transshipment points, repackaging, falsified documentation, updated to reflect the regulations of each country the package transits through. The parcel arrives in the United States looking, on its customs documentation, like a shipment of industrial solvents or laboratory reagents. It is neither. The volume of international parcel traffic, hundreds of millions of packages annually flowing through American ports of entry, makes comprehensive physical inspection impossible. Automated screening catches some, the rest move through. A single dose of naloxone in the 4 mg nasal spray formulation retails without insurance at somewhere between $140 and $180 in the United States. This is the standard reversal medication. For fentanyl overdoses, 1 dose was often sufficient. For nitazene overdoses, some documented reversals required 4 doses or more. If a community naloxone distribution program has been stocking kits calibrated for fentanyl, which is to say, calibrated for the crisis they understood, those kits may be insufficient for the crisis that has arrived. Scaling up the kits means scaling up the cost. Scaling up the cost requires funding that flows through the same political processes that have consistently underfunded harm reduction infrastructure throughout the opioid crisis. The people producing nitazenes have no overhead in this sense. No regulatory compliance, no public comment periods, no funding cycles. They produce, they ship, they collect payment. The externalized costs, the overdoses, the emergency department visits, the deaths, the community harm reduction programs running out of naloxone, are paid by someone else. They are paid by the people who use the supply, by the families of people who die, by the emergency systems that absorb the medical expenditure, and by the public funds that pay for whatever response the political system eventually produces. The margin on nitazene production is extraordinary. The cost is borne entirely by others. This is not an accident of the market. It is the structure of it. There is one more economic dimension to this that does not appear in standard policy discussions, because it requires acknowledging something uncomfortable about the demand side of the equation. People with opioid use disorder who have developed significant tolerance, whose bodies have adapted to high levels of opioid stimulation to the point where a dose that would be dangerous to a naive user produces little effect in them, are, in a pharmacological sense, in search of potency. Not necessarily deliberately, not necessarily with knowledge of what they are seeking, but the escalation of tolerance and the escalation of supply have a relationship. Fentanyl's extreme potency made it attractive to this population in ways that heroin was not. Nitazenes, for a distributor who understands this, are a product that addresses a market need. The supply hits harder. Customers return. The fact that the margin between what the customer wants and what kills them has narrowed further as a risk the producer has transferred entirely to the customer. This is the economics of the invisible made complete. The compound is invisible in the test strip. The risk is invisible to the person using it. The cost is invisible to the people producing it. And the scale of the problem remains, for now, largely invisible in the public conversation. No household name, no political campaign, no cultural moment that has made nitazenes what fentanyl became. The production continues. The distribution continues. The grey market suppliers update their catalogues when specific compounds are scheduled and replace them with variants that are not. The infrastructure built over years of fentanyl trade carries the new payload without modification. The notes are still in the databases. The suppliers are still in business. And the kits carried by the people responding to overdoses were calibrated for a different drug. On the 14th of October 2020, the DEA published its emergency scheduling action, placing Isotonitazene into Schedule 1 of the Controlled Substances Act. The action had been in preparation since the compound was first identified in seized samples the previous year. It went through the appropriate channels. It was published in the Federal Register. It was, by the standards of regulatory response to an emerging drug threat, fast 14 months from first detection to scheduling is not a long time in a system that normally moves in years. The scheduling action meant that Isotonitazene was now illegal to manufacture, distribute or possess in the United States without authorization. It meant that anyone caught with it faced serious federal charges. It meant that the compound had a name in the system, a Schedule I designation, and the full weight of federal drug enforcement behind the effort to remove it from circulation. Metanitazene was already in transit, not metaphorically, not as an approximation. The seized samples that identified metanitazene in the United States drug supply began arriving at forensic labs within months of the isotonitazene scheduling action. The compound had not been synthesized in response to the scheduling action. Synthesis, shipping, and distribution take time, and the timeline suggests that whoever was producing it had not waited for the regulatory process to conclude before preparing the next product. They had, in all likelihood, been working on it while the scheduling action was still in progress. The isotonitazene action was a signal. The signal had been read. The response was already in the mail. To understand why this keeps happening, it helps to understand what scheduling actually does and what it cannot do. Scheduling a compound makes it illegal. It authorizes law enforcement to prosecute people who manufacture, distribute, or possess it. It closes the legal grey area that allowed the compound to exist in a regulatory limbo, sold as a research chemical, marketed under misleading labels, moving through commercial shipping channels with a veneer of ambiguity. Scheduling removes the ambiguity. It makes the legal status unambiguous. It is a necessary step. What it cannot do is remove the knowledge. The synthesis route for isotonitazene is in the published literature. Scheduling the compound does not remove it from the literature. The literature is not under the DEA's jurisdiction. The DEA can make isotonitazene illegal. It cannot make the knowledge of how to produce isotonitazene illegal. And the knowledge of how to produce isotonitazene is, for a chemist familiar with benzimidazole synthesis, also the knowledge of how to produce metanitazene, and protonitazene, and etodesnitazene, and flunitazene, because these compounds are structural variations on the same scaffold. The menu does not disappear when one item is removed. The menu gets an asterisk next to one item. The other items remain. Metanitazene is isotonitazene with a different methyl group placement. The pharmacological effect is similar. The potency is comparable or higher. The structural difference is sufficient, under the specific language of the scheduling action, to sit outside the isotonitazene designation. A chemist producing metanitazene after the isotonitazene scheduling action is not, technically, producing a scheduled substance. Until metanitazene itself is scheduled, which takes time, during which time metanitazene is in the supply. This is the scheduling carousel. It is not a new phenomenon. It is not specific to nitazenes. The fentanyl era ran it first, and ran it extensively, and the pattern was documented and analysed and discussed at length in public health and policy literature, while the deaths continued. Carfentanil, acetylfentanyl, furanil fentanyl, butyryl fentanyl, each one a structural variant of fentanyl, each one appearing in the supply shortly after its predecessor was scheduled, each one requiring a new emergency scheduling action, each action buying months rather than years before the next variant emerged. The playbook was known, the outcome was documented. The nitazene carousel is running the same sequence, with the added complication that the source material, the CIBA research, the broader benzimidazole pharmacological literature, describes not 2 or 3 variants but an entire chemical family. Protonitazene followed metonitazene, then etodesnitazene, then flunitazene, then butonitazene. Each compound followed the pattern, detected in seized samples, identified by forensic labs, flagged in surveillance systems, processed through scheduling channels, placed into Schedule 1 or the equivalent in international jurisdictions, and replaced within the same general time frame by the next variant. The European Monitoring Centre for Drugs and Drug Addiction, the EMCDDA, the body that tracks drug trends across European Union member states, issued a rapid communication in 2023 noting that 14 distinct nitazene analogues had been detected in drug supplies across Europe and North America within a 3-year window. 14 compounds, 3 years. The communication flagged the proliferation rate as exceptional even by the standards of synthetic opioid analogues. Faster than the fentanyl analogue proliferation, more diverse in structure, covering a wider range of the chemical family. 14 compounds in 3 years, 1 every 2.5 months on average, though the average flattens what was actually a clustering pattern. Periods of apparent stability followed by the sudden appearance of 2 or 3 new compounds within weeks of each other, as if producers had been holding variants in reserve, ready to deploy when the previous one was scheduled, which may, in fact, be what was happening. The grey market supply chain is not reactive in the way a small operation might be. It has logistical lead time, it has production cycles, a supplier who anticipates that Isotonitazene will be scheduled, which is not a difficult thing to anticipate given that all novel psychoactive substances in this potency range eventually attract scheduling attention, can begin producing the next analogue before the action lands. The DEA recognised the limits of compound-by-compound scheduling. In 2023, using its emergency scheduling authorities, the agency moved to schedule a broader class of nitazene compounds collectively, attempting to close the analogue gap by covering not just specific named compounds, but structural classes defined by their chemical properties. The intention was to get ahead of the carousel rather than perpetually chasing it. This was the right instinct. The question was whether the language was broad enough, and whether the chemistry was cooperative enough to make it work. The answer from the fentanyl era was not encouraging. The DEA had attempted similar class-based scheduling for fentanyl analogues, using the Federal Analog Act, legislation from 1986 designed to cover substances substantially similar to scheduled compounds. The Act's application to novel psychoactive substances had been inconsistent in practice. Prosecutors had to demonstrate substantial similarity in court, which required expert testimony, and the definition of substantially similar became a site of legal contest. Compounds designed to be just different enough created genuine ambiguity about whether the Act applied. The class scheduling for fentanyl had slowed the carousel. It had not stopped it. For nitazenes, the challenge is compounded by the scope of the chemical family. The benzimidazole opioid class is large. The structural variations possible within it are numerous. The CIBA research program in the 1950s described dozens of compounds with varying potency profiles. The literature since then has added to that picture. A class-based scheduling action to be effective would need to be broad enough to cover variations that have not yet appeared in the supply, which means covering compounds that may not yet have been synthesized, whose properties may not be fully characterized, whose legal status under a class definition would require analysis that can only happen after the compound exists. The scheduling action is drafted in the present, the chemistry operates in the future. What the carousel reveals, when you watch it run, is something about the structure of the problem that policy responses tend to obscure. The carousel is not a failure of enforcement. Enforcement is doing what enforcement does. Compounds are being identified, named, scheduled, and prosecuted. The system is functioning. The carousel keeps turning anyway, because the carousel is not a law enforcement problem with a law enforcement solution. It is a knowledge problem. The knowledge of how to produce these compounds is in the public domain. It cannot be unscheduled. It cannot be seized. It cannot be prosecuted. It is in databases that will remain accessible regardless of what the DEA does with any specific compound. This is the specific way in which nitazenes differ from most controlled substances in the history of American drug policy. Heroin is derived from poppies. Cocaine is derived from coca leaves. Methamphetamine requires precursor chemicals that can be tracked, interdicted, and made more difficult to obtain. These supply chains have physical choke points. They can be disrupted, not eliminated. The history of drug policy is the history of supply chains adapting to disruption, but disrupted. Nitazenes have no agricultural component, They have no precursor chemical that is unique to their production, and that does not appear in legitimate industrial chemistry. And the synthesis knowledge is not in the possession of a cartel or a network. It is in peer-reviewed journals. It is in university library databases. It is, in a meaningful sense, everywhere. The DEA can schedule a compound the day it appears. The next compound is already being prepared. The carousel turns at the pace of chemistry, not at the pace of regulation. By 2024, the catalogue of detected nitazene analogues had exceeded 14. The number continues to change. New compounds appear in seizure data, get identified by forensic labs, enter the surveillance systems, and begin the process of working their way through scheduling. Some are potent enough to attract immediate emergency action. Some are potent enough that the forensic lab on identification issues an alert to public health agencies before the scheduling process has concluded, because the scheduling process will take months and the compound is in the supply now. The floor, as the story has been noting, keeps moving. The carousel is one of the mechanisms by which it moves. Schedule a compound, the floor drops by one step. Another compound appears, the floor drops by another. The steps are not equal in size. Some analogues are more potent than the ones they replace, some less. But the direction is consistent. The direction is down. There is a version of this story in which the carousel is the most alarming part. 14 compounds in 3 years is an extraordinary figure. The rate of proliferation is faster than the regulatory system was designed to handle. The class scheduling action may slow it. It will not stop it. The chemistry knows no deadline and respects no filing period. But the carousel is also, in a specific and uncomfortable way, not the worst part. The carousel is visible. Each new compound gets identified, gets named, enters the data. The compounds that appear in the carousel are being tracked. Forensic labs find them. Surveillance systems log them. The number 14 is a number that came from somewhere. From labs running screens, from seized samples, from the infrastructure of detection doing its job. The worst part is not what the surveillance systems find. The worst part is what they miss. And what they miss is not a small amount. Before the surveillance systems, before the scheduling actions, before the forensic labs and the regulatory processes and the public health alerts, there is a person. And what happens to that person is not a policy question. It is a pharmacological one, and then a medical one, and then something that does not fit neatly into either category. Nitazenes work the way all opioids work. They bind to the mu-opioid receptor, a protein on the surface of nerve cells, found in high concentrations in the brain, the spinal cord, and throughout the body. When an opioid binds to this receptor, it activates it. The activation produces a cascade of effects: analgesia, sedation, euphoria, slowed breathing. The slowed breathing is the mechanism of death. Respiratory depression, the technical term for breathing that becomes too shallow, too slow, and eventually stops, is what kills in an opioid overdose. The receptor does not distinguish between a therapeutic dose administered in a hospital and a street dose administered by someone who does not know what they have taken. It responds to what binds to it. Nitazenes are full agonists at the mu-opioid receptor. They bind tightly. They activate it completely. They are, in this sense, doing exactly what they were designed to do. Ezio Zurcher synthesized them as analgesics, and they are extraordinary analgesics. The problem is the dose. The margin between the dose that produces the desired effect and the dose that causes the receptor to suppress breathing past the point of recovery is, for the most potent compounds in this family, not a margin in any practical sense. It is a line. And the line is drawn in a material that is invisible, in a product that gives no warning, at a threshold that the person using it cannot know. The onset is faster than heroin. In some cases, faster than fentanyl. This detail matters in ways that extend beyond pharmacology. With heroin, a person who begins to overdose typically has a window. minutes, in some cases longer, during which someone present might notice the signs and respond. With fentanyl, that window narrowed significantly. The onset of respiratory depression is faster, the progression more rapid. People who were using in groups sometimes didn't notice that someone had stopped breathing until it was nearly too late. People who were using alone had less time before consciousness went. With nitazenes, particularly with the higher potency compounds in the family, the window is shorter still. Reports from emergency responders and from people who survived inadvertent exposure describe an onset that happens before the expected experience does. The warmth, the sedation, the onset of euphoria that a person with opioid use disorder would recognize as the beginning of the drug's effect. And then, faster than expected, nothing. Not the gradual transition from high to unconscious that heroin produced. Something more abrupt. The effect and the overdose arriving so close together that the person has little time to recognize that something is wrong before they are no longer in a position to respond to it. This is what inadvertent exposure looks like from the inside, to the extent that there is an inside to report. Most of the people who have experienced nitazene effects and survived did not know they were experiencing nitazene effects. They knew something was different. They could not always say what. The reports that exist come primarily from harm reduction workers and emergency department staff, reconstructed from survivors who could describe only fragments. The moment the drug hit differently than expected, and then a gap, and then waking up, sometimes with the marks of naloxone administration already on them, sometimes not knowing how long had passed or what had happened. What the overdose looks like from outside is a different picture, and it is the one that the people responding to it have to work with. The signs of a nitazene overdose are the signs of any severe opioid overdose: unconsciousness or unresponsiveness, slow or stopped breathing, the blue or grey colouring around the lips that indicates oxygen deprivation. The responder, whoever that is, a paramedic, a bystander, a family member who has been trained in naloxone administration, a harm reduction worker doing street outreach, recognizes the presentation. They have seen it before. They know what to do. They reach for naloxone. Naloxone works by competing with the opioid for the mu-opioid receptor. It binds to the receptor without activating it, displacing the opioid and reversing the respiratory depression. The mechanism is the same regardless of which opioid caused the overdose. What varies is how much naloxone is needed and how long it takes to work. With heroin, the standard dose of 2 milligrams of intranasal naloxone was typically sufficient. A single spray, wait, reassess. The person often responded within minutes. With fentanyl, 2 milligrams was sometimes not enough. The higher potency of the compound, and in some cases its faster binding to the receptor, meant that a full reversal sometimes required a second dose. The standard moved. Community naloxone kits were updated. The 2 milligram spray became standard, with the understanding that a second dose might be needed. With nitazenes, the compounds that are more potent than fentanyl, which is already 100 times more potent than morphine, 2 milligrams is often insufficient. 4 milligrams may be insufficient. Some documented reversals have required 6, 8, or more milligrams of naloxone before the person began breathing on their own. The responder administers the first dose, waits. The person is not responding. Administers the second, waits. Still not responding. The third. At some point, the question becomes, how much naloxone is there? A community naloxone kit carries a standard quantity, calibrated for the crisis the kit was designed to address. If that crisis was fentanyl, the kit was calibrated for fentanyl. If the crisis has changed, if what is in the supply is something more potent than fentanyl, the kit may not be enough. The responder reaches the end of what they have. The person is still down. And the compound has not finished with them. There is a second dimension to the naloxone problem that is less widely understood than the dose issue, and in some ways more dangerous. It has to do with the half-life. Half-life is the time it takes for the concentration of a substance in the body to fall to half of its peak level. Different drugs have different half-lives. Naloxone has a relatively short half-life, somewhere between 30 and 90 minutes depending on the formulation and the individual. This is normally not a problem with heroin, which also has a relatively short duration of action. The naloxone reverses the overdose, the heroin clears, the person recovers. Fentanyl has a longer half-life than heroin, and this created a clinical problem during the fentanyl crisis. A person reversed with naloxone could re-enter overdose once the naloxone wore off, if the fentanyl had not yet cleared their system. Emergency departments learn to monitor reversed overdose patients for longer periods, rather than discharging them immediately after reversal. Some nitazines have half-lives longer than fentanyl. The duration of action for compounds like mitonitazene and protonitazene is not fully characterized. The clinical literature on human exposure is limited for obvious reasons, but the available evidence suggests that the compound can remain active in the body for longer than the naloxone used to reverse it. A person reversed in the field, appearing to recover, may re-enter respiratory depression after the naloxone wears off. If they are alone when this happens, if the responder has left, if the person has declined transport to an emergency department, if no one else is present, the second overdose may not be survived. This is not a theoretical scenario. It is a documented pattern in high-potency opioid overdose, and the evidence from nitazene-related cases suggests it applies here. The reversal is not always the end of the emergency. Sometimes it is the interval. Emergency departments that have updated their protocols for high-potency synthetic opioid overdose, which is not all of them, and which has happened unevenly across the country depending on the training available and the clinical guidance reaching frontline staff, have extended their observation periods for reversed overdose patients. The standard fentanyl-era protocol involved observing a reverse patient for a period after naloxone administration, then making a discharge decision based on whether the person appeared stable. For nitazene overdose, the appropriate observation period is longer, because the compound's half-life may exceed the naloxone's, and because the signs of re-entry into respiratory depression can be subtle in the early stages. A person who appears stable at 1 hour may not be stable at 2. The discharge decision is also complicated by the practical realities of emergency medicine. Emergency departments are under sustained capacity pressure. A person who has been reversed, who appears conscious and oriented, who declines admission or further care, has a legal right to leave. The clinical staff cannot detain them, they can advise them not to use again, can offer referrals to treatment, can provide additional naloxone. They cannot prevent the person from walking out the door, and if the compound in that person's system has a half-life that extends beyond their time in the department, the reversal they received inside may not still be active when they encounter the drug again, or when the drug finishes with them outside. The withdrawal dimension adds another layer. Some nitazenes, because of their extended half-lives and their potency at the mu-opioid receptor, produce withdrawal syndromes that are more prolonged and more severe than heroin withdrawal. The clinical literature on this is limited. Human exposure data is sparse for the obvious reason that most people do not know they have been exposed, but the pharmacological reasoning is sound. A compound that binds tightly to opioid receptors and remains active for longer will, when it clears, leave a more abrupt and sustained deficit. For a person who has been using a nitazene-contaminated supply regularly without knowing it, the withdrawal they experience when the supply changes or becomes unavailable may be longer and more difficult than they have previously experienced, and may drive them back to the supply that is causing it. The people most likely to encounter nitazenes without knowing it are people with opioid use disorder who are using street supply. This is not a simple category. It includes people who have been using opioids for years and have developed significant tolerance, whose bodies require doses that would be fatal to someone naive to opioids just to achieve a level of function they can maintain. It includes people who are using intermittently, with varying tolerance, whose vulnerability fluctuates with their use pattern. It includes people who have recently left treatment or incarceration, whose tolerance has dropped, and who return to a supply that is now more potent than when they left. The inadvertent exposure dynamic operates differently across this population. The post-incarceration and post-treatment window is among the highest risk periods in the opioid crisis under any conditions. A person leaving prison after a sentence of months or years has had their tolerance reset. Their body has adapted to the absence of opioids, and the dose that was manageable before incarceration will be substantially more than manageable now. This is a well-documented cause of death in the opioid crisis under fentanyl. A person is released, returns to their prior supply, uses what they previously used, and the gap between their prior tolerance and their current physiology is fatal. The supply that was normal before is now an overdose. Nitazenes make this gap larger. If the supply has changed during the person's incarceration, if what is circulating now contains compounds more potent than what circulated before, the person returning to that supply is encountering something more dangerous than they left. They have no way of knowing this. They have been incarcerated. The information about what is in the current supply has not reached them. The harm reduction programs that might have provided that information and updated naloxone training do not have access to prisons and jails in most jurisdictions. The person walks out with a plan to use the supply they remember, encounters a supply that has changed in ways they cannot see, and the distance between their expectation and their reality is the distance between alive and not. For a person with high opioid tolerance, a nitazene-contaminated supply may produce an effect they interpret as quality. The supply hits harder, which is what they were seeking. They may survive the encounter. They may return to the same supply. They may tell others about it. The compound that was most likely to kill them becomes, through the mechanism of tolerance and the economics of the drug market, a product with word-of-mouth appeal. For a person with low or variable tolerance, the same supply can be fatal. The margin that high tolerance provides is not reliable. A person who has been using less than usual, who has taken a break, who has a physical illness that affects their metabolism, who is using a different route of administration than usual, any of these variables can shift where on the potency curve they encounter the compound. The compound does not adjust. It is what it is, at whatever concentration it was mixed to, which is itself a variable, because the mixing is not consistent, and the person who did the mixing is not a pharmacist. The person using the supply has no information about any of this. They have a substance they believe to be what they were sold. They do not know what it contains. They do not know the potency of what it contains. They do not know their own position on the risk curve on this particular day. They proceed on the assumption that today's supply is similar to yesterday's, because that has usually been true, because that is the only assumption available to them. What this looks like, aggregated across the population of people using nitazene-contaminated supply across 30 or more American states, is a rolling emergency that looks, from the outside, like an extension of the fentanyl crisis. The overdose presentations are similar. The responders use the same medication. The emergency departments receive the same category of patient. The deaths appear, in standard toxicology, as opioid-related deaths. The difference is invisible. The difference is in what compound caused the death, and how it got there, and what that means for the response. A death recorded as fentanyl-related because the toxicology screen ran for fentanyl and found it and stopped there, may have been caused or contributed to by a nitazene compound that the screen did not look for. A person reversed and discharged from an emergency department, whose discharge is recorded as a successful fentanyl overdose reversal, may re-enter overdose in the parking lot because the compound in their system has a half-life the reversal protocol did not account for. The data captures the visible surface of this. What is underneath? How many deaths? How many near misses? How much of the ongoing opioid crisis toll is being driven by a compound that the standard surveillance infrastructure does not see? Is not recorded. It is not recorded because the screens do not run for it. And the screens do not run for it partly because the equipment and the funding are not there, and partly because the policy systems that direct the screens are calibrated to the last crisis, not the current one. The responder has used what they carried. The person is stable, for now, if they are stable. The compound has not cleared, the half-life has not expired, the naloxone, when it wears off, will not be replaced by anything. The surveillance system will record what it can see. What it cannot see will not be recorded, and the recorded number, whatever it is, will be smaller than the real one. When someone dies of a suspected drug overdose in the United States, the body goes to the medical examiner. The medical examiner orders a toxicology screen. The toxicology screen runs for a panel of substances, the compounds the lab is equipped to detect, the compounds that appear frequently enough in the caseload to justify the cost of screening, the compounds that the jurisdiction has decided through some combination of clinical judgment and budget allocation and historical precedent are the ones worth looking for. Fentanyl is on the panel, heroin metabolites are on the panel, cocaine, methamphetamine, a range of prescription opioids, benzodiazepines. The panel was built over time in response to the drugs that were killing people, and it reflects the crisis that existed when the panel was last updated. Nitazenes are, in most jurisdictions, not on the panel. This is not negligence. It is a resource problem with an institutional logic behind it. A comprehensive toxicology screen, one that could identify novel synthetic compounds from an effectively unlimited chemical family, requires mass spectrometry analysis that is more expensive and more time-consuming than the immunoassay-based screening that constitutes standard toxicology practice in most medical examiner offices. Immunoassay screening is fast and cheap and accurate for the compounds it is designed to detect. For compounds outside its target set, it returns nothing. It does not return a negative result that signals something was missed. It returns nothing, which looks identical to a clean screen. A person who dies with isotonitazene in their system in a jurisdiction whose toxicology panel does not include isotonitazene will receive a toxicology result that shows fentanyl if fentanyl was also present. And in much of the current drug supply, fentanyl is present in some form alongside other compounds. The death is recorded as a fentanyl-related death. The isotonitazene is not recorded because the screen did not look for it. The medical examiner is not wrong. The medical examiner is recording what the test found. The test found what it was built to find. The result is a death toll with a category error embedded in it. The fentanyl era produced a version of this problem that took years to fully recognize. When illicit fentanyl first began appearing in the heroin supply in the early 2010s, the deaths it caused were initially attributed to heroin, because heroin was what the toxicology screens were calibrated to find, and because the clinical presentation of a fentanyl overdose and a heroin overdose are similar enough that, without specific testing, they are difficult to distinguish. It took time, years of data, updated screening protocols, targeted research, to understand how much of the overdose death toll was attributable to fentanyl rather than heroin, and how quickly fentanyl had displaced heroin as the primary cause. That delay had consequences. The response to a heroin crisis and the response to a fentanyl crisis are not the same. The harm reduction tools are different. The naloxone dosing considerations are different. The supply chain interventions are different. Policy calibrated to heroin was calibrated to the wrong drug, and by the time the data caught up, the crisis had already taken a different shape than the response was built for. The nitazene situation is structurally the same problem at a later stage. The data is being recorded, but the category may be wrong. The toxicology screen finds fentanyl and stops, or finds an unknown opioid and records it as such, when the compound producing the fatal respiratory depression was something else entirely, something more potent, with different pharmacokinetics, whose presence would change how the death is understood and how the response should be designed. The cost of fixing the counting problem is concrete and known. A comprehensive toxicology screen using liquid chromatography mass spectrometry, the technology capable of identifying novel synthetic compounds including nitazenes, costs significantly more per case than a standard immunoassay panel. Medical examiner offices operate on fixed budgets allocated by county or state governments. The decision about which tests to run on which cases is a resource allocation decision made within those budget constraints by offices that are already chronically underfunded relative to their caseloads. In many jurisdictions, comprehensive synthetic opioid screening is run only on cases flagged as unusual, where the standard panel returns nothing but the presentation is consistent with opioid overdose, or where a cluster of deaths in a specific area prompts targeted investigation. Routine screening is not comprehensive, it is calibrated to what the budget allows. The implication is that the true cost of not running comprehensive screens is externalized onto the people who die without being accurately counted, and onto the policy systems that make decisions based on incomplete data. The direct cost of expanded screening, more expensive tests, more lab time, more expertise, is visible and budget line specific. The cost of the undercount, deaths misattributed, responses miscalibrated, resources misallocated, is diffuse and invisible. Budget decisions consistently favour the visible cost over the invisible one. The result is a surveillance system that captures what it can afford to capture and misses what it cannot. Tracy Green, a researcher at Boston Medical Center and Brandeis University, who has spent years tracking synthetic opioid overdose patterns, has been among the most consistent voices raising this concern. Her surveillance work has documented the geographic spread of nitazene compounds across the United States and flagged repeatedly the gap between what the standard surveillance infrastructure captures and what is likely happening in the supply. The deaths recorded in the opioid crisis data represent a real number. The real number is larger. How much larger is precisely what the current infrastructure cannot tell us, because measuring the gap requires the tools that would close it. The 30-plus states figure, the number of American states where nitazene compounds have been detected in seized drug samples or toxicology analysis, is frequently cited as evidence of the scale of the problem. It is evidence of something, but it is worth being specific about what. It is evidence of the scale of the problem as detected by the infrastructure that's currently looking. The infrastructure is not comprehensive. States with better funded forensic labs, more robust drug surveillance systems, and active drug checking programs find more nitazenes, not because they have more nitazenes, but because they are better equipped to find them. States with underfunded medical examiner offices, limited toxicology capacity, and no active drug checking infrastructure find fewer, or none, for the same reason that a screen that does not run for nitazenes does not find nitazenes. The 30-plus figure is a floor, not a ceiling. It is the number of states where someone looked and found something. It says nothing reliable about the states where no one has looked, or where the looking is insufficient. Australia provides an instructive parallel. When Australian researchers and public health authorities began specifically testing for nitazene compounds, prompted by international alerts and by clusters of unexplained overdoses, they found them. 3 deaths in separate Australian states in 2023 confirmed as nitazene-related on specific testing. Australia's standard toxicology infrastructure, which had not been built to look for nitazenes, had not detected them in prior testing. The compounds had been present in the supply. The infrastructure had not been looking. The deaths, until the targeted testing was conducted, had been recorded as something else or as unknown. Canada's experience with metanitazene in British Columbia and Ontario followed a similar pattern. The compounds appeared in drug-checking data, in samples brought in by people who use drugs and analysed by services with mass spectrometry equipment, before they appeared in medical examiner toxicology results. The harm reduction infrastructure, which was specifically designed to identify novel compounds in the drug supply, found the problem first. The formal surveillance system, running its standard panels, caught up later. The pattern across Australia and Canada illuminates what the difference in detection infrastructure actually produces. In jurisdictions that invested in drug-checking services and targeted toxicology, that added nitazene panels to their standard screens after international alerts flagged the compounds as emerging threats, the data improved. More deaths were accurately attributed. The response could be calibrated to the actual compound. Harm reduction workers could issue specific warnings about specific compounds in specific supply chains. The information reached the people most at risk faster and with more specificity than in jurisdictions still running standard panels. This is what improved detection infrastructure produces. It does not prevent the compounds from arriving. It does not stop the supply chain. What it does is close the gap between what is happening and what the response knows is happening. And that gap as the fentanyl era demonstrated, is where the preventable deaths accumulate. What closing that gap fully would require in the United States is a combination of expanded toxicology, capacity at the medical examiner level, sustained funding for drug checking services in the communities most affected, and a surveillance system capable of sharing data across jurisdictions quickly enough to be actionable. None of these things are technically difficult. The technology exists, the trained personnel exist, or could be trained. The institutional structures for coordination exist in modified form from the CDC's drug overdose surveillance infrastructure. What does not exist consistently is the political will to fund and sustain these systems at the scale the problem requires. This is the recurring dynamic of the synthetic opioid crisis. The harm reduction infrastructure, working at the edge of the problem with the people most directly affected, detects the threat first. The formal surveillance systems, working within their standard protocols and budget allocations, confirm what the harm reduction workers already knew. The gap between detection and confirmation is time during which people die without the response being calibrated to what is killing them. The policy consequence of this is specific and underappreciated. Public health and emergency response systems allocate resources based on data. If the data says the primary driver of overdose deaths is fentanyl, the resources go to fentanyl-calibrated responses. If the actual driver is a compound more potent than fentanyl, requiring more naloxone per reversal, producing longer duration overdoses, undetectable by fentanyl test strips, then the fentanyl-calibrated response is systematically misallocated. Not wrong in kind, because naloxone and harm reduction services are necessary regardless of which opioid is in the supply. Wrong in degree and in design. The kits carry the wrong amount. The protocols are built for the wrong duration. The test strips check for the wrong compound. The undercount problem is not a statistical abstraction. It is a mechanism by which the policy response stays one crisis behind. The fentanyl response arrived, by most accounts, years after it was needed. The nitazene response, if it follows the same pattern, will arrive after the same category of delay, after the deaths have accumulated long enough that the data is undeniable, after the screening infrastructure has been updated, after the harm reduction community's early warnings have finally been confirmed by formal surveillance systems. In the interim, the recorded number is what it is. Medical examiners file their reports, the data is compiled, the statistics are published, and somewhere in those statistics, in the fentanyl-related deaths, and the unknown opioid deaths, and the polydrug overdose deaths, there are people whose deaths were caused or substantially contributed to by a compound the panel did not look for. The number of those people is unknown. That unknown is not passive, it is active. It shapes the response, or rather it misshapes it, bending the allocation of resources and attention toward the recorded crisis, while the actual crisis continues at a scale the recording does not capture. There is a phrase used in intelligence and policy analysis: known unknowns. The things you know you do not know, the gaps in the data that you are aware of, even if you cannot fill them. The nitazene death toll is a known unknown. The people working in drug surveillance, in harm reduction, in forensic toxicology, in public health research. They know the number is wrong. They know the recorded figure understates the reality. They cannot tell you by how much, because the tools that would answer that question are the same tools whose absence creates the problem. What they can tell you is that the fentanyl death toll, when it was finally understood accurately, was larger than anyone had recorded while it was accumulating. The years of mislabeled deaths, attributed to heroin while fentanyl was already dominant, represent a period during which the response was pointed at the wrong target. The nitazene situation is, by the available evidence, in an earlier version of that same period. The compounds are in the supply, the screens are not running for them, the deaths are being recorded under other categories. The people closest to the problem, the harm reduction workers, the drug checking service operators, the researchers like Tracy Green who have been tracking this since the first samples appeared in 2019, have been saying so for years. Their data is real. Their concern is documented. The formal surveillance infrastructure is beginning to catch up. How long that takes, and what the accumulated toll looks like when it finally becomes fully visible, is the question the current data cannot answer. What it can answer is this: the number we have is not the number that is real. The real number is larger. The distance between those two numbers is, for each person it represents, not a statistical question at all. The harm reduction workers found it first. This is not a rhetorical point. It is a documented feature of how novel synthetic opioids enter public awareness, and it has repeated itself consistently across the fentanyl era and into the nitazene era. The drug checking service operators, the street outreach workers, the needle exchange staff, the people running naloxone distribution programs in cities with high rates of opioid use disorder, they encounter the drug supply directly, from the people using it, before the formal surveillance infrastructure processes the data that confirms what they are seeing. They found nitazenes in samples before public health agencies had issued formal warnings. They issued their own alerts, through their own networks, to the people most at risk. The formal system caught up later. This is worth dwelling on for a moment, because it inverts the usual assumption about how public health information flows. The assumption is that knowledge moves from researchers and agencies outward, toward the communities affected. In the synthetic opioid crisis, the flow has frequently run the other direction. The communities affected, or more precisely the workers embedded in those communities, have the information first and spend months or years trying to move it upstream into the formal systems that have the authority and resources to act on it at scale. Tracy Green, whose surveillance work at Boston Medical Center and Brandeis University tracks synthetic opioid overdose patterns, has described this dynamic in her research. The early nitazene detections came through drug checking services, programs that analyze samples brought in by people who use drugs and report back on what they find. Those services found Isotonitazene and then metanitazene in samples that the people who brought them in believed to be heroin or fentanyl. The services issued alerts. The information reached other harm reduction workers, reached emergency departments in some cities, reached researchers monitoring drug trends. The formal toxicology data at the medical examiner level took longer to reflect what the drug checking services already knew. A drug checking service, at its core, is a translation technology. It takes a substance that a person believes to be one thing and tells them what it actually is. The technology that makes this possible is mass spectrometry, an analytical technique that identifies compounds by their molecular weight and fragmentation pattern, producing a chemical fingerprint that can be matched against a reference database. A mass spectrometer can identify isotonitazene. It can identify metanitazene. It can identify compounds that have no name yet in the scheduling system, flag them as unknown, and initiate the process of characterizing them. It does not have a target list. It looks for everything and finds what is there. This is categorically different from a fentanyl test strip. The strip is an immunoassay. It uses antibodies designed to bind to fentanyl and fentanyl-like compounds, producing a color change if those specific compounds are present above a threshold concentration. It is cheap, fast, and effective for its intended purpose. Its intended purpose is detecting fentanyl. Nitazenes are not fentanyl. The antibodies do not bind to them. The strip comes back negative regardless of what concentration of nitazenes is present. The practical implication is stark. A person who uses a fentanyl test strip on a supply that contains metanitazene, but no fentanyl, receives a negative result. The strip is functioning correctly. It found no fentanyl. It was not designed to find metanitazene, and it did not. The person believes the supply is safe to use. The information they acted on was accurate within its own terms and useless as a guide to their actual risk. A drug-checking service with mass spectrometry equipment would have identified the metanitazene. The person could have been told what was in their supply. They could have adjusted, used a smaller amount, used with someone present, carried additional naloxone, made an informed decision about whether to use at all. This is harm reduction working as it is designed to work. The knowledge exists. The question is whether the person who needs it can get to it. In most American cities, they cannot. The number of drug-checking services with mass spectrometry capability operating in the United States is small relative to the scale of the opioid crisis. The equipment is expensive. A research-grade mass spectrometer capable of identifying novel compounds costs tens of thousands of dollars, requires trained operators, and needs ongoing calibration and database updates as new compounds appear. The funding for these services runs through a patchwork of grants, public health allocations, and private philanthropy that is inconsistent across jurisdictions and vulnerable to political shifts in the willingness to fund services for people who use illicit drugs. Cities with strong harm reduction infrastructure, some urban centres in the northeast and on the west coast, have access to drug-checking services. Large portions of the Midwest and South, where the opioid crisis has hit hardest, and where nitazene detections have been concentrated, have minimal access or none. The access problem is not uniformly understood as a political problem. It is sometimes framed as a resource problem. There is not enough money. But money is a political allocation. The decision not to fund drug-checking services in a given jurisdiction is a political decision made by people who answer to a constituency about whether the lives of people who use illicit drugs are worth the expenditure required to keep more of them informed and alive. The framing as a budget problem obscures the question being answered. Brandon Del Pozo, who spent years as a police chief before becoming a researcher at Brown University, has been among the most direct voices on this. His work on the failure of law enforcement-only approaches to synthetic opioid waves makes a specific argument. Interdiction and scheduling are not substitutes for harm reduction, and treating them as substitutes produces predictable results. The carousel keeps turning. The compounds keep arriving. The people in the supply chain bear no cost from the enforcement actions. The people using the supply bear all of them. What Del Pozo and researchers like him advocate for is not an abandonment of enforcement. It is a parallel investment in the infrastructure that keeps people alive while enforcement does what it can do and fails at what it cannot. More naloxone, in higher doses, in more hands. More drug-checking access so that the people using street supply can know what is in it. More treatment capacity so that people who want to stop using can access services that actually work. These are not controversial interventions in public health terms. Their controversy is entirely political, a matter of who receives the benefit and whether that population is considered worth protecting. The treatment access dimension of the nitazene crisis is the part of the picture that rarely appears in discussions of synthetic opioid policy, possibly because it is the most structurally intractable. The opioid crisis has, since its beginning, been partly a treatment access crisis. The medications that are most effective for opioid use disorder, buprenorphine and methadone, are both tightly regulated in the United States in ways that create significant access barriers, particularly in rural and under-resourced communities. Buprenorphine requires a prescription from a provider who has completed specific training. The number of such providers relative to the population needing treatment has been chronically insufficient, though regulatory changes in recent years have begun to address this. Methadone for opioid use disorder can only be dispensed through federally certified treatment programs, clinics that require daily or near-daily visits, that are geographically concentrated in urban areas, and that have waiting lists in many jurisdictions. The connection to nitazenes is direct. A person with opioid use disorder who cannot access treatment, who is on a waiting list, who lives too far from a clinic, who cannot afford the cost of buprenorphine without insurance, who has had bad experiences with treatment systems and is not ready to engage, continues to use street supply. That street supply now contains nitazene compounds they cannot detect. The treatment access crisis and the nitazene detection crisis are not separate problems. They are two dimensions of the same structural failure, a system that has been consistently inadequate to the scale of the problem it's addressing, that has remained inadequate through each successive wave of the crisis, and that is now inadequate to a wave that is more dangerous than the previous ones. Del Pozo's argument, grounded in his experience as both a law enforcement officer and a researcher, is that the response to synthetic opioid waves requires simultaneous investment across multiple dimensions. Not enforcement instead of harm reduction, not harm reduction instead of treatment, but all three, at scale, sustained. The evidence from the fentanyl era suggests that interventions deployed in isolation do not move the mortality numbers. Enforcement alone does not stop the supply chain. Harm reduction alone cannot compensate for the absence of treatment options. Treatment alone cannot reach people still in active use who have not yet decided to seek it. The combination, funded adequately and deployed consistently, is what the research supports. The combination is not what has been deployed. The naloxone distribution problem has a specific shape in the nitazene era that it did not have in earlier phases of the opioid crisis. During the fentanyl crisis, the consensus in harm reduction practice moved toward higher dose naloxone, from 2 mg to 4 mg as the standard community kit, because fentanyl overdoses sometimes required more than the original 2 mg formulation. That shift happened through a combination of clinical observation, harm reduction advocacy, and eventual policy change. It was not fast. It lagged behind the evidence by years. But it happened. The nitazene era requires another shift, toward even higher doses, carried in larger quantities, with training that accounts for the longer duration of overdose and the possibility of re-entry into overdose after initial reversal. Some harm reduction organisations in cities where nitazene detections have been documented have already begun updating their protocols, providing kits with more doses, training community members in the signs of re-entry overdose, advising people not to leave a reverse person alone. This is the harm reduction community doing what it has always done, adapting faster than the formal policy system, with less resources, to a problem the formal system has not yet officially acknowledged at the scale it is operating. The cost barrier is real. A 4 mg naloxone nasal spray retails at over $140 without insurance. A kit that provides enough naloxone for a nitazene overdose reversal, potentially 4 to 8 mg or more, with additional doses in reserve, represents a significant expense for programs operating on grant funding. The pharmaceutical economics of naloxone are a separate and bitter story, one that intersects with the nitazene crisis at the specific point where the cost of the medication needed to reverse the overdose has increased precisely as the overdoses have become harder to reverse. The geography of the drug checking access gap maps almost exactly onto the geography of the opioid crisis. The states with the highest overdose death rates, West Virginia, Ohio, Kentucky, Tennessee, the rural Midwest and Appalachian corridor, are the states with the least drug-checking infrastructure. The cities with robust drug-checking services, certain urban centres in the Northeast, some West Coast cities with strong harm reduction traditions, are not the cities most devastated by the crisis at the population level, though they have significant need as well. The communities that have been most harmed by the opioid crisis are the communities least equipped, in terms of harm reduction infrastructure, to detect and respond to the next wave of it. This is not coincidental. It reflects decades of decisions about where to fund public health services and where not to, decisions shaped by political calculations about which communities are seen as worth protecting and which are expendable. The communities most devastated by the opioid crisis are disproportionately rural, disproportionately white working class, and in many cases located in states whose political leadership has been most resistant to harm reduction approaches as a matter of ideological principle. The people dying are not dying because the tools to reduce harm do not exist. They are dying in places where those tools have not been sent. The people doing this work do not, for the most part, appear in the public conversation about the opioid crisis. The crisis gets covered when death tolls reach new records, when a celebrity overdose makes the news, when a political figure announces a new enforcement initiative. The harm reduction workers distributing naloxone in parking lots and shelters and encampments, the drug-checking service operators running mass spectrometers in storefronts, the researchers updating their surveillance databases at midnight because the data from the day's samples has come in. They are not the story that gets told. They are the story that is actually happening. What they know, collectively, is more current and more specific than what appears in formal surveillance reports. They know which compounds are in the supply in their cities right now, because they tested samples from people who use drugs right now. They know the naloxone protocols are insufficient, because they have witnessed reversals that required more than the standard kit. They know the fentanyl test strip does not catch nitazenes, because they tested supplies that came back negative on the strip and positive on the spectrometer. They know all of this, and they issue alerts and update their protocols and train their staff and run their programs on funding that is always uncertain and always insufficient. What they cannot do is close the gap alone. The gap between what is known at the harm reduction level and what is resourced at the policy level is not a gap in knowledge. It is a gap in will. The information has been moving upstream for years. The researchers have published. The harm reduction workers have documented. The alerts have been issued. The question of whether the response scales to match the problem is not a question that harm reduction workers can answer. It is a question for the political systems that control the allocation of public resources. The information exists. The tools exist. The gap between where they are and where they need to be is not technical. It is not technical at all. The systems built to respond to heroin were not built for fentanyl. This is a fact about the opioid crisis that is now widely acknowledged, primarily because it is no longer possible to look at the fentanyl death toll and argue otherwise. The naloxone kits carried by first responders in 2012 were calibrated for heroin. The harm reduction infrastructure, the needle exchanges, the outreach programs, the treatment centres, was designed around a population using heroin and the specific challenges heroin presented. The toxicology panels at medical examiner offices were built to find heroin metabolites. The drug-checking tools that existed were built for the drug that existed. And then fentanyl arrived, and none of it was adequate, and the inadequacy cost hundreds of thousands of lives before the systems could be rebuilt, partially, unevenly, never completely, for the new reality. The systems built for fentanyl are not built for nitazenes. This is the same sentence one wave later. It will in all likelihood be the same sentence one wave after that. The legacy of nitazenes, as of 2024, is not a story with an ending. It is a story in the middle of itself, which is the most uncomfortable kind. The crisis is ongoing. The compounds are in the supply. The carousel is turning. The counting infrastructure is inadequate. The harm reduction community is doing what it can with what it has. The treatment system is as underfunded and inaccessible as it has been throughout the opioid crisis, which is to say, significantly. The policy response is calibrated, as policy responses typically are, to the last crisis rather than the current one. What nitazenes have demonstrated specifically and clearly is that the synthetic opioid problem has no inherent flaw. This is the observation that does not appear in political discussions because it does not lend itself to political solutions. But it is what the evidence shows. The flaw is not a pharmacological property. It is not a limit imposed by chemistry. There is no molecule so potent that chemistry cannot produce something more potent. There is no compound so dangerous that the logic of the illicit market, extreme potency, tiny volume, high margin, does not apply to something worse. The flaw is wherever the combination of economic incentive, available knowledge, and regulatory pressure happens to settle in a given moment. And the regulatory pressure, as the carousel has demonstrated, consistently creates incentive to move the flaw rather than hold it. Heroin was the flaw once, then fentanyl, then the nitazene family, with its multiple analogues and its potency range extending to 1,000 times morphine and above. Where the flaw is now is a function of what is in the seized samples being analysed this week. Where it will be next year depends on what the grey market suppliers decide to produce, which depends on what gets scheduled, which depends on what gets detected, which depends on what the toxicology infrastructure is looking for. The floor keeps moving. That is not a metaphor. It is a description of what the data shows. The question that the Nitazene story raises and that the story cannot answer is whether anything breaks the pattern. The pattern is specific. A new class of synthetic opioids enters the supply. The detection infrastructure identifies it, usually after deaths have accumulated. The regulatory system schedules it. The producers pivot to structural variants. The variants enter the supply. The detection infrastructure identifies them. The regulatory system schedules them. The producers pivot again. The cycle runs until the chemical family is exhausted, or until something disrupts the economic logic that drives it. The fentanyl family has not been exhausted. The nitazene family has not been exhausted. The disruption has not arrived. What would break the pattern is a subject of genuine disagreement among the researchers, clinicians, harm reduction workers, and policy analysts who work on synthetic opioid crises. There is no consensus answer, partly because the problem is new enough in this specific form that the evidence base is limited, and partly because the solutions that are most strongly supported by the existing evidence are also the most politically contested. The supply-side interventions, scheduling, interdiction, international pressure on production source countries, have a consistent track record in the fentanyl and nitazene eras. They slow the carousel, they do not stop it. The knowledge cannot be unscheduled. The precursor chemicals have legitimate industrial uses that prevent them from being banned outright. The supply chains are adaptive, decentralized, and embedded in legitimate commercial logistics infrastructure in ways that make comprehensive interdiction essentially impossible at the volumes involved. This does not mean supply-side interventions are worthless. They impose costs on producers, disrupt specific supply chains, and buy time. But the evidence does not support the conclusion that they can stop the carousel by themselves. The demand-side interventions, expanded treatment access, harm reduction at scale, policies that reduce the criminalization of drug use and the barriers to seeking help, have a different evidence base. The countries with the most robust treatment and harm reduction infrastructure have not eliminated synthetic opioid crises, but they have managed them at lower mortality rates than countries that have relied primarily on enforcement. Portugal's drug decriminalization policy, implemented in 2001, is the most discussed example. A country that shifted resources from prosecution to treatment and harm reduction, and saw significant reductions in drug-related deaths and disease. Switzerland's heroin-assisted treatment program, which provides pharmaceutical heroin to people with severe opioid use disorder under medical supervision, has decades of evidence supporting its effectiveness in reducing illicit drug use, criminal activity, and mortality in its participants. Canada's supervised consumption sites, facilities where people can use drugs under medical supervision and receive immediate overdose reversal if needed, have a documented record of preventing deaths without increasing drug use in surrounding communities. None of these interventions solve the problem of synthetic opioid potency. What they do is reduce the harm produced by that potency by putting medical infrastructure between the user and the compound in ways that can compensate for the margin of error that the compound provides no room for. A person using nitazenes under medical supervision, with staff present who have naloxone and the training to use it, is less likely to die than a person using the same compound alone in a parking lot with a kit calibrated for fentanyl. This is not a political statement. It is a description of what being present with adequate medication and training does relative to being absent. The open question in the nitazene story, the one that the researchers who track synthetic opioid trends consistently raise, and that the current evidence cannot resolve, is whether nitazenes will remain primarily an adulterant or will become a sought compound. So far, most nitazene exposure is inadvertent. People are not buying nitazenes. They are buying heroin or oxycodone or fentanyl and receiving nitazenes without knowing it. The compounds have not, as of the most recent available evidence, developed the kind of cultural profile that would make them a drug people specifically seek. They do not have brand recognition. They do not have a community of deliberate users who have adopted them as their compound of choice. They're in the supply as a contaminant, a highly potent, highly dangerous contaminant, rather than as the product itself. This may not remain true. The history of synthetic opioid use patterns suggests that compounds initially encountered as adulterants can become sought drugs if they develop a reputation for particular qualities, a specific effect profile, a particular onset, a duration that users find desirable. Fentanyl moved through this process. It began as an adulterant in heroin, became a compound some users deliberately sought for its specific effect profile, and eventually displaced heroin as the primary product in much of the illicit opioid market. If a nitazene analog develops characteristics, whether of effect, of duration, of availability, or of cost, that make it attractive as a deliberate choice rather than an inadvertent encounter, the user population's relationship with the compounds changes. The risk profile changes. The harm reduction interventions that are appropriate change. The policy response has to change. None of this has happened yet. Whether it will happen is genuinely unknown. The researchers who monitor this space note it as a concern rather than a prediction. But the fentanyl trajectory provides a template, and the template is not reassuring. Ezio Zurcher's notes are still in the databases. This is the fact that the story keeps returning to, because it is the fact that the story cannot move past. The knowledge that produced nitazenes is not sequestered. It is not classified. It is not held in proprietary databases accessible only to licensed researchers. It is in peer-reviewed journals indexed by the same academic databases used by graduate students writing literature reviews. It is findable with a search query. It describes not one compound but an entire chemical family, with synthesis routes, potency data, and pharmacological characterization. The work that Zurcher and his colleagues did at CIBA in the 1950s, published in the spirit of scientific transparency, is still there exactly as they left it. And the work of the researchers who came after, the occasional pharmacological studies, the academic characterizations of additional benzimidazole compounds, the incremental additions to the scientific record over 60 years, is also there, also indexed, also findable. The benzimidazole opioid family that CIBA's research describes has not been fully explored in the illicit market. 14 compounds have been detected. The family is larger than 14 compounds. Whether the compounds that have not yet appeared in the illicit supply are more or less potent than the ones that have is a question the published literature can answer. A chemist with access to the literature and the ability to perform benzimidazole synthesis has, in the published research, a menu that extends beyond what the scheduling actions have so far covered. The menu is not complete. There are structural variations possible within the family that have not been synthesized and characterized. But what is there is enough to represent a range of options that the regulatory system has not yet addressed. This is the specific reason why the floor keeps moving. Not because the producers are especially innovative, but because the source material is exceptionally rich. Zurcher was thorough. The research program was systematic. The publications were comprehensive. The database that contains them does not expire. What the opioid crisis has demonstrated across 30 years and multiple waves is a specific kind of institutional lag. The response arrives after the problem, not because the people responding are incompetent. Many are exceptionally capable and are working under conditions of sustained resource scarcity and political ambivalence. The lag is structural. It is built into systems that are reactive by design, that respond to what is documented, that allocate resources to what is recorded, and that make decisions based on data that is always, to some degree, a portrait of the recent past rather than the present. The synthetic opioid crisis accelerated this lag problem beyond what the institutions were designed to handle. Heroin changed slowly. Supply routes shifted over years. Potency varied within a relatively narrow range. The pharmacology was understood and the response could be calibrated to it. Fentanyl changed fast. It entered the supply in a matter of years, displaced heroin as the primary opioid in much of the market within a decade, and drove death tolls to levels that required a fundamental recalibration of the response infrastructure. Nitazenes are changing faster still, more analogues in less time, greater potency range, structural diversity that makes class-based scheduling more difficult, and a source material that is still in the public databases providing options the scheduling system has not yet reached. The institutions that respond to this are not designed to move at this speed. They were not designed to respond to a crisis that changes faster than they can document it. Fixing that would require not just more resources, though more resources are necessary, but a different model of response. One that invests in anticipatory infrastructure, surveillance systems that look for what might appear rather than only cataloguing what has appeared, drug checking services deployed before the crisis rather than after, treatment capacity scaled to the population that needs it rather than the population that has historically been served, harm reduction approaches funded consistently rather than through grant cycles that create gaps in coverage. The model that has produced the current situation, reactive, resource-constrained, politically contested, is the model that produced the lag, and the lag has a body count. The opioid crisis became so chemically extreme that fentanyl stopped being enough. This is the claim at the centre of the Nitazene story. It is not a dramatic exaggeration. It is a literal description of what the supply chain evidence shows. Fentanyl, 100 times more potent than morphine, responsible for tens of thousands of deaths annually, was not the end point. It was a point in a trajectory that has continued moving in the same direction. The direction is toward more potency, less detectability, smaller margins for error, and higher cost for everyone except the people producing it. The compounds that Ezio Zurcher synthesized in Basel in 1957, rejected by his company as too dangerous to use, published in the scientific literature as a record of what had been tried, were not supposed to be here. They were supposed to be the endpoint of a research program that concluded with the correct decision not to proceed. The decision was correct. The publication was correct. The assumption that the information would function as a warning rather than a resource. That was the assumption that turned out to be wrong. The compounds are here. They are in 30 or more American states. They are in Canada, in Europe, in Australia. They are in supplies that people believe to be something else. They are invisible to the test strips that harm reduction programs distribute. They require more naloxone to reverse than the standard kits carry. They are being counted imperfectly in a surveillance system that is calibrated to the last drug rather than this one. The people who know the most about them are working in underfunded programs on inconsistent grants in cities that are not always the cities where the problem is most acute, and the notes are still in the databases, the carousel is still turning, the grey market suppliers are still operating, the floor is still wherever someone decides to look for it next. This is not where the story ends, this is where it is.